All right. I think it's 1 o'clock. Is that what others feel like it is too? I don't like to dilly-dally, even though I know that there's some providers who may just wander in if they're seeing patients or whatever. But Hannah, do you want to start? Is there anything you need to start with, or can I just start away?
You can jump right in.
Great. Okay. So hello, everybody. I'm Jen Funderburk. I'm here with Amber Landers, who I don't think has her camera on any longer, but we're the co-directors for the Research and Evaluation Committee. And just wanted to give you a little exposure to what that is before we have our amazing presenter speak with you today. So the Research and Evaluation Committee is all volunteers who are members of CFHA. And we are charged with by the board to try to assist in ensuring the organization stays true to the impact of evidence-based practice. And so we do that in a lot of different ways. And we can also be asked by the board to do specific activities. But some of the initiatives that we do regularly is we put on webinars each year on specific topics, like the one you're going to hear today. We have specific conference activities, and those of you who are attending our annual conference in October might get exposed to the Research and Evaluation Committee training track, which is really focused on presentations that teach you something about evaluation, quality improvement, and research skills. Hot Off the Presses has been one of those for the last couple of years, where we kind of, and I'll share with you why that happens, but usually you walk away from that particular presentation with a skill that you can apply towards a program evaluation effort, a quality improvement effort, or if you broadly do research. And it's very rare. I've never seen it at a conference before, and I think a lot of people seem to value it. And then we also have a rec fellowship, which actually applications will be opening in the next couple months, usually is May or June, where we select an early career professional who is doing either a quality improvement or program evaluation effort, who we want to recognize with that award. It is led by the Leadership Council, and there's a number of us, at least 9 or so of us on it. We meet monthly to make these activities happen. But if you're interested in becoming a part of that, or even if you just want to volunteer in one small way, we would love to have you. So feel free to reach out to us. On that slide, you can see Amber's email, and so you can reach out to her, and she'll figure out how to best kind of involve you. But let's move on to the more important part of the experience, which is Dr. Shephardson's presentation today. We're calling this Hot Off the Presses 2 because she was nice enough to repeat a presentation that she did at the annual conference for those of us who may have missed it because you weren't able to be there in person for whatever reason. And this is it's been a regular presentation at the last couple of conferences where the Research and Evaluation Committee we review recent research, rigorous research, that has direct application within integrated care. And most of the time over the last couple of years, it's been focused on randomized controlled trials of brief interventions that can be integrated into that setting. And Dr. Shepardson agreed to come back and talk to us about her randomized controlled trial that she recently finished on a brief modular cognitive behavior anxiety intervention in integrated primary care. Dr. Shepardson is a clinical research psychologist at the VA Center for Integrated Healthcare. I get the pleasure of working with her every day, and it makes my job much more enjoyable than it would be without her. She's done a lot of research in integrated care, both in anxiety and other topics. And I think you will come to enjoy her presentation. She's got a lot of good findings to share with you today. She also was a member of the Research and Evaluation Committee and led it for a period of time. So we're really thankful for her continued involvement. And I'm going to pass the baton over to her. Thank you, Robyn.
Great. Thanks, Jen. Thanks to the REC for having me. I'm happy to be here and present. welcome to everyone who's here. Glad to be able to tell you about this study, whether you're a researcher, clinician, or another role. I hope you'll find this interesting, and I look forward to some time for questions and discussion at the end. So I'm going to tell you about this modular intervention and a clinical trial that we did. And I want to just acknowledge my co-authors, including Dr. Funderburk, but also Dr. Johnson, Gass, and Mike Wade from our center. It takes a village to do these kind of trials. And sorry, I gotta get my slides. There we go. Before I get started, I will just let you know I haven't had any conflicts of interest. This work was funded by the VA Health Services Research Service, so we appreciate their help. Couldn't do the study without the funding or the support of the VA Center for Integrated Healthcare, where Jen and I work. Please know that everything I share with you is our team's views. It's not the official position or policy of the federal government or the Department of Veterans Affairs. And lastly, we just wanted to give a thank you to our team of research staff in the service lab. Could not have done the study without them. As you'll see, it involved a lot of work, as well as the patients and providers who participated. Okay, so like Joe was saying, this is a recently completed trial. The paper is still actually under review, so this is very fresh data that we're presenting. And, you know, it's important, whatever your role is in integrated care, to stay up to date in the research. So I hope you will find this interesting. And what we're going to, let's see. Well, there we go. Okay, sorry. What we're going to cover today will hopefully help illustrate why it's helpful to understand more about research that happens in integrated care. I'm going to tell you about the brief anxiety interventions. You can understand what that looks like, because it's a little bit different from how some protocols are set up, and then we'll get into the results of the actual clinical trial. So I have focused on anxiety for my work because there's a big gap in terms of treatment for anxiety in primary care. If you work in primary care, I'm sure I don't have to tell you that it's very common in primary care patients. Between 15 and 20% of primary care patients meet criteria for an anxiety disorder diagnosis, and many more have subthreshold symptoms that are clinically significant. Anxiety is the second most common reason patients get referred to PCBH for care. But unfortunately, in primary care, only about half of patients receive quality treatment, whether that be medication or behavioral treatment. Typically, most of the anxiety treatment in primary care is medication. So there's a big gap, a lot of patients who need help, and PCBH is well equipped to help with that. But providers need evidence-based interventions that will work. So there's a ton of empirically supported treatments for anxiety that exist, but they were developed for specialty mental health settings. And we can't use them in PCBH. It's just not feasible. We can't do 12-hour-long sessions once a week or what have you. So providers are kind of, getting creative and dabbling with different hodgepodge of treatment elements that they're adapting from longer form treatments, and doing a little bit of everything in their intervention. So we did a survey study with providers to see what do providers deliver when they have patients with anxiety, and we found that most often it was psychoeducation, relaxation, training, and supportive therapy. And all those things are perfectly fine, and they have their place and they're useful. But for anxiety, we know that CBT interventions, and especially exposure therapy and cognitive therapy, are very powerful. And those things really aren't being used in primary care that often because providers find it difficult to do them in brief sessions. Different brief CBT interventions have been shown in reviews to be effective in primary care, but most of the protocols that have been tested in primary care are very disorder specific. So they tend to focus on generalized anxiety disorder and panic disorder specifically, but there's very high comorbidity across anxiety disorders. There's also high comorbidity with depression. So about half to 2/3 of patients with anxiety disorder also have depression. There's a lot of patients who have subthreshold symptoms. They don't quite meet for a disorder and what have you. So it's a little bit murky what's going on. So having a protocol that works just for GAD or something isn't optimal. So providers need something that is going to work for what they're seeing. So our team collaborated to develop a new modular intervention. So we call it Modular Anxiety Skills Training, or MAST. You might also hear me say VAST, Veterans Anxiety Skills Training. That's our acronym that we use. So I reviewed the literature as part of a career development award. I reviewed the literature on different anxiety treatments for primary care and kind of adapted it together into this new form of a modular CBT intervention that is transdiagnostic, meaning it can work across anxiety presentations. I'll tell you about that more in a minute. It's really patient-centered, tailored to individual patients, and especially for this audience, tailored for the PCBH setting. So I'm going to tell you a little bit more about these pieces. So first, evidence-based. This is very important that we ground this treatment in what we know works. So evidence-based care combines the best available research evidence with clinical expertise and recognition of the importance of the patient in terms of their characteristics, culture, and preferences. So MAST is grounded in the cognitive behavioral therapy model, but there's extensive evidence for that with anxiety, but also recognizes the role of clinicians. The clinician's role is very important for guiding the patient through treatment, tailoring the treatment to them, tailoring the psychoeducation to the specific anxiety presentation. And the patient preferences are very important as well. So patients and providers work together to collaboratively select the modules. On the right of this slide is our CBT model that we showed to patients to give them a visual to understand the interconnectedness of thoughts, feelings, behaviors, physical sensations, and that helped with setting up the treatment rationale so they understood why we were targeting different things that we were targeting in the treatment. This was tailored for the PCBH setting. We worked very hard in the pilot work to put this together in a format that would fit with busy practice in PCBH. So the treatment involves up to 6 sessions of 30 minutes each. It can be done face-to-face, video, phone, however you need to do it. It's consistent with the 5 A's approach that a lot of folks use to kind of organize how they view sessions. We start with a focused functional assessment of what's going on, and then provide psychoeducation on anxiety as well as coping skills, which I'll show you in a minute. The emphasis is really on skills training, though, active skills training of learning skills that folks can use, practicing, learning them in session and practicing them at home for homework. We set SMART goals for the skill practice. And we use measurement-based care. So the GAD-7 and PHQ-9 are given at every session to help track progress and inform selection of modules. And overall, there's a collaborative therapeutic style like is so common in PCBH. Okay. I don't know. Okay, there we go. Okay. This is transdiagnostic, which means we designed it so it will be applicable across all the DSM-5 anxiety disorders. So everything but OCD and PTSD, which we already have, either we have good treatments for in specialty care or primary care setting, and they're different kinds of disorders. So I'm focusing on all the other like non-trauma related anxiety. So MAST is applicable whether the presentation be panic, social anxiety, generalized, ruminative worry type of thing, phobias, adjustment-related anxiety, unspecified anxiety. And we're targeting kind of the underlying mechanisms of anxiety disorders, and we're able to use a similar approach to treatment regardless of the specific flavor of anxiety that we're seeing. It was also important to us that we were able to accommodate common comorbid concerns that we see with anxiety. So, 50% or more of patients with anxiety have depression. It's very common that people have sleep difficulties, very common that people have psychosocial stressors and things going on. And so we wanted to make sure we could address those concerns as well because people are complex and they have a lot going on. MAST is modular. So modular means it has different components that can be delivered in different order. depending on what the patient needs. So it's not one size fits all. We know that doesn't work. Different pieces that we select based on the patient's needs and preferences. There's a lot of advantages to modular treatment. It is a manualized treatment. There's a full manual for the protocol, but the modular aspect allows for flexibility with which therapists like and patients like. But modular treatment's been found to be just as, if not more effective than standard treatments where people progress through the same order of components. And modular treatment is more efficient and therapists actually like it more. Here are the modules in MAST. We had our Veterans Research Engagement Board help us come up with the names of these modules so they're easy for patients to understand. The green one at the top and the bottom, those are the standard sessions everybody gets. So everybody starts with assessment, functional assessment of anxiety and psychoeducation about anxiety to lay the groundwork for the treatment. And everybody ends with relapse prevention planning, consolidating their learning and giving them a plan to maintain their gains. In between is where the patients get to personalized treatment. So the 3 yellow lines are the core modules. Those are our kind of central ones that we tried to emphasize. We had patients pick one of those to start so that they could get intervention that addressed either the behavioral, cognitive, or physiological component of anxiety. And exposure, cognitive therapy, and relaxation all have strong evidence for anxiety. And then after that, they could do some of the other core modules or the optional modules, which are the 4 you see in blue there. So we included mindfulness because there's good evidence for mindfulness with anxiety. And then the other 3 are the comorbid concerns related to sleep, stress, and mood. So patients could mix and match these however they wanted in terms of whatever made the most sense given their unique anxiety presentation. We, before the current trial, we pilot tested MAST in RCT, comparing it to PCBH usual care. So half the patients got MAST, half the patients got PCBH usual care, and we had good evidence of feasibility and acceptability. The figure on the left there is showing you our process outcomes with the MAST in blue and usual care in orange. And you can see that MAST outperformed usual care in terms of therapeutic alliance, treatment credibility, and treatment satisfaction. We were very excited about the alliance finding in particular because a lot of clinicians believe that a manualized treatment will impede their ability to develop rapport with their patients, but we did not find that. We found the opposite, actually. The 2 graphs on the right there are showing you the clinical outcomes. So the top one is showing that usual care patients basically kind of stayed the same, decreased slightly, but not significantly, whereas the patients who got MAST decreased significantly on the GAD-7. The figure on the bottom is showing you that in terms of anxiety severity and impairment from anxiety, the usual care group was kind of flat. They didn't really change over time, whereas the MAST group did decrease significantly over time. So those were promising pilot findings that led us to get the funding to do the larger trial. But this is a small trial with insufficient power, so we need to do a full-scale trial to really test things. So that led us to the current study. This was a multi-site randomized controlled trial in which frontline clinicians in PCBH delivered the intervention and the comparison condition. And it was done in a routine care setting, not a research setting. And the goal was to compare clinical outcomes between the intervention and usual care over a 16-week period that we allowed as our treatment period. We hypothesized that the modular CBT intervention would outperform usual care. And we also examined if gains were going to be maintained over a 3-month follow-up period. So it was a hybrid 1 trial, so we were collecting data relevant to implementation, such as treatment fidelity data, while we're also doing the effectiveness trial. Patients were randomized. We had 2 sites that are randomized by site and also symptom severity level at baseline. So the patients who were mild to moderate versus severe were spread across the sessions in case that could have a relation to outcome. Patients were recruited primarily from case finding for people that were seen in primary care, and their doctor noted they had some anxiety in the past month, and then we called them and screened them. We screened almost 800 veterans for this. About a third of them were eligible, and about 2/3 of those enrolled. It was done at 2 VA systems. It took like a little over 3 years to recruit all the patients. So again, a lot of work goes into these RCTs that you might see published in articles. And then the figure is showing the procedure of the trial. They did the baseline assessment, they were randomized to condition, and then they did some follow-up assessments once a month until post-treatment, and then we did our 3-month follow-up. We targeted adult primary care patients with anxiety. We used a cutoff of a score of 8 or higher on the GAD-7. So GAD-7 is a widely used measure in primary care, and an 8 is chosen based on prior research. That puts them kind of right in the middle of the mild severity range on the GAD-7. They did not have to have an anxiety disorder diagnosis. They just had to have this level of symptoms. And the exclusion criteria are pretty standard, no significant cognitive impairment, no imminent suicide risk, no concurrent therapy, they're already in therapy, that sort of thing. We excluded people who had OCD and PTSD or likely PTSD. We excluded people who had severe depression. So if they had a 20 or higher on the PHQ-9, we did exclude them just because only one module in the treatment focuses on depression. And we felt that in that level of severity, it would be best to treat the depression first. People could be on medication as long as their dose was stable for 30 days. So these are pretty standard inclusion exclusion criteria. And we ended up with 169 participants. Again, they were randomized to PCBH usual care or the mass intervention. We had a good age range, 23 to 82 there, an average of 50. We had 30% women, which we were excited about because in the VA, the percentage is usually closer to 10 or 15%. So we were excited that we were able to recruit a lot of women. Mostly white race, which is consistent. This was done in central and western New York, so consistent with the local patient population, but overall 19% identified as racial or ethnic minority status. We had good diversity in terms of socioeconomic status, income, education, that sort of thing. There were no differences between condition in demographics except for sex. So the PCBH usual care condition had a significantly higher percentage of women than mass just by chance, but otherwise the groups were similar. And they also were similar on baseline clinical characteristics. And on average, patients reported moderate severity symptoms of anxiety on the GAD-7 and on the PHQ-9. About 40% of the patients were in the moderate range on the GAD and 20% in the severe range. And comorbid depression was common. We also did a diagnostic interview to assess for disorders. 40% met criteria for an anxiety disorder at baseline. Only 11% met criteria for depression episode at baseline. And there's no differences between condition on the clinical variables. So randomization worked as we hoped it would. Okay, let's see. Okay, our providers, we had 36 providers in the study, which was 75% of those that we invited. So this was a really good showing in terms of getting frontline clinicians to participate in the study because they had to agree to be randomized to condition. So we randomized them because we didn't want people's unconscious, biases about CBT or evidence-based treatment or manuals or their motivation to learn something new or any factor like that that could be related to how they did in treatment. We randomized so that we split everything across condition. In the end, a few people did not see patients just due to logistical reasons or leaving leaving their role or something, but 16 providers saw patients in usual care. 16 providers saw patients in the intervention condition. On average, people saw 4.5 patients, so that's a good sample of their treatment provision. The providers were mostly white women in psychology, but we did have about 40% master's level providers with social work and even some licensed mental health counselors. These folks were a mixture of full-time PCBH clinicians and like trainees, interns, and fellows. Our sites have a lot of interns and fellows who rotate through PCBH, and they're always interested in studies like this. But we had a good number of full-time folks as well. About 75% of them reported their theoretical orientation was CBT, and then a lot were integrative or eclectic. Okay. And sorry, every time this thing doesn't want to advance, I have to click it about 10 times to get it to advance. So hang with me until it clicks. Okay. Our outcomes. So our primary clinical outcome was the OASIS, the Overall Anxiety Severity and Impairment Scale. This gets at both the severity of symptoms as well as the impairment that anxiety is causing you in your home life, work life, and social life. So this is a really nice outcome because in PCBH, we really care about affecting people's functioning, not just the symptoms. We did, of course, have symptom measures. We used the DAS-21 anxiety and depression subscales. We collected GAD-7 and PHQ-9 as well, but because those were given so often clinically as part of measurement-based care, we wanted to have a different measure just in case there was any kind of learning factor or fatigue with the GAD-7 and PHQ-9. We did have many other secondary and tertiary outcomes, but for the sake of time, I'm going to focus on these outcomes. And our analytic approach, we use multi-level modeling. And, so we're accounting for different levels of care in terms of the site with different therapists, with different patients, with different time points. We used an intent to treat analysis, which means we use everybody's data regardless of if they had some missing data. And our hypothesis was that there would be an interaction, a time by condition interaction. So we'll see if we found that or not. Here's our retention data in the trial. So our team did amazing reaching these participants. It was a 7-month study, and there was 6 time points, 5 follow-ups, and the team was able to do over 90% of assessments across 850 assessments. So just amazing retention, which increases our confidence in the results because most people were retained. At post-treatment in particular, we had 88% of the sample. So that was really exciting to see. But this is just showing you, there was a lot of hard work going into getting these data to be able to analyze them for this trial. Okay, so before I show you the results, I will first address the comparison condition. So again, we use PCBH usual care as our comparison because we're trying to see if the intervention improved on what's already happening in PCBH. But what does it mean, PCBH usual care? So we had providers record all of their sessions, and we randomly selected a quarter of them to have research staff listen to them and rate what happened during the session. So we're trying to get a sense of what are we comparing the modular intervention to. And these are data from the first half of the sessions we rated. So 43 sessions, most of which were follow-up sessions. And we rated not only the techniques that were used in the mass intervention, but also a bunch of other therapy techniques that could possibly happen in a session. And we kind of used a very generous definition of what counts as one of these techniques. But you can see in the table that 2/3 of the sessions included some sort of cognitive behavioral therapy psychoeducation, helping people to understand the model. 40% of sessions include some degree of relaxation training or cognitive therapy. And just to again, with the generous view of what that means, 40% of the sessions talked about relaxation in some way, whether that be encouraging the patient to try relaxation or giving them a handout or giving them an app. But only 7% of the sessions included a demonstration of a relaxation exercise like deep breathing or something. So they're touching on these topics, but what that looks like in many cases is kind of a brief mention of something versus like a more in-depth skills training that might have happened in the intervention condition. But you can see all the techniques that are in the intervention from the modules are happening in usual care, although maybe not as common as they were happening in the intervention condition. So that's something to keep in mind when we interpret the results, is that there is overlap in what's happening in the treatment. Okay, so now we'll get into the actual results. So this graph is showing you the primary outcome OASIS, so anxiety, severity, and impairment over time. The solid blue line is usual care. The dotted red line is the intervention condition. These are intent to treat results, which means that we included everybody, regardless of what, if they had missing data, regardless of whether they got treatment, what dose of treatment, high quality treatment, everyone's data, no matter what. And you can see at baseline, the groups were about a 9 on this measure. So the clinical cutoff on the OASIS is 8. So both groups were, on average in the clinical range on the OASIS, and they both decreased over time from baseline to 16 weeks. They both decreased significantly. And so drawing your attention to the circle there to our post-treatment at 16 weeks. So they both went down, usual care to about an 8 and the intervention group to about a 9. So not a huge decrease, but it was statistically significant, but there was not an interaction. And I'll show this clear on the next slide. From post-treatment, 16 weeks to our follow-up at 28 weeks. So over those 3 months, the intervention condition continued to improve significantly, and the usual care group improved slightly, but it wasn't statistically significant. So when I'm talking about the lack of an interaction, this helps show that a little bit. So the 2 bars, they have a similar slope. If there was an interaction, they would kind of be crossed in some way, for example. But you can see they both went down. They're kind of parallel-ish, more or less. So that's showing that they're not significantly different. They started at slightly different places and they both went down. But both groups getting significantly better is a good outcome, but not what we expected. Now we're looking at the DAS-21 anxiety subscale. So this is just a straight up anxiety symptom severity measure. Again, the solid blue line is PCBH usual care. The dotted red line is the intervention condition. At baseline, both groups were about 10.5 or 11. At post-treatment, in the green circle, the usual care group was about a 9. The intervention group was about an 8. Both groups decreased significantly over time. And again, there was no interaction or difference between conditions. Both groups stayed steady over the follow-up. So no rebound effect in terms of decaying, but they didn't keep improving, but they held their gains, which is good. So similar pattern to the impairment measure that we just saw. Again, no significant difference. Here, the slopes are a little bit different than parallel, but not a significant difference, once again, in terms of the conditions. Finally, I'm showing the depression severity graph. So this is the DAS-21 depression symptom severity. Blue line is usual care. Dotted red line is the intervention. They started slightly different places there, and then at post-treatment, both had gone down significantly. If you eyeball it, it's maybe the red one went down more, but it wasn't significantly different. And once again, no decaying. They didn't get worse after post-treatment. They both held out. They didn't change significantly. And then just showing those slopes again. I can get these slides to change. They did not differ significantly. Goodness. I never had this. There we go. They both went down significantly, but at a similar rate. So, okay. So for all three of these outcomes, including our primary outcome and other outcomes that I don't have time to show you, including the impairment related to anxiety, both groups improved significantly over time. The only difference between them was the intervention group continuing to get a little bit better after post-treatment, but otherwise the same pattern. So our overall hypothesis that the intervention would outperform usual care was not supported. But it was great to see that both conditions actually were effective, right? So it's good news that PCBH usual care is effective for anxiety. And we think that usual care was actually more effective than we were anticipating. And this was interesting. So at first it was like, this is weird. Like, is this inconsistent with prior research? If you recall at the beginning, I told you that reviews have found that brief CBT for anxiety is effective in primary care. But you have to kind of look a little bit further into the details of the studies, and then it makes more sense. So we looked through actually all of the trials of brief CBT for anxiety that have been done in primary care that were in 4 different meta-analytic reviews, and almost always the comparison did not involve an active behavioral treatment, which was kind of surprising. So they almost always compared to a non-psychotherapy condition, whether that be waitlist or placebo medication. In those cases, the patient is not getting any active treatment, right? They're either waiting, they're getting nothing, or they're getting an inactive placebo. Or primary care usual care, which is the most common comparison condition that's been used in prior treatment. And that means whatever your PCP gives you. And, some people have a great mental health minded PCP who might either give them a prescription for an anxiety medication, refer them to treatment, or do some supportive counseling themselves. But the whole reason, I'm doing this work is because patients in primary care do not get adequate treatment. So when we look at studies that examine what is primary care usual care, it's typically nothing. Even in cases when the primary care physician is alerted to the existence of an anxiety disorder, maybe 10% of people get behavioral treatment. So really, primary care usual care is most of the time in these studies, no behavioral treatment. So it's kind of comparing apples to oranges if you're comparing psychotherapy to no psychotherapy. We compared apples to apples, right? So we compared behavioral treatment to behavioral treatment, which almost nobody has done. Again, much to our surprise, that hasn't really been done. So this is one of the first RCTs, as far as we know, that has compared brief CBT to a psychotherapy comparison condition. And so in that context, our results that both groups got better makes more sense because, yes, they actually got, good treatment, the treatment that you and your colleagues are giving to folks, which is quality treatment. So that helps us contextualize these results. And if you recall from the usual care description data that I showed you, there are overlaps between what was happening in usual care and the intervention. People in usual care are doing some of these CBT techniques, although at different doses and in a different form than what's happening in the intervention. So that was interesting. A few other things that we thought about as we were trying to interpret the data is that this was like a real world trial, and that is helpful in terms of its applicability to what happens in clinical practice. But that is complicated when you think of the research side of it, because things aren't always cut and dry as we would like them to be in research. So one thing that was notable is our anxiety inclusion criteria. It was an 8 on the GAD-7. And if people were seen, we screened them and then we did their baseline assessment within 2 weeks. We did not rescreen them for anxiety. And so we had a subgroup of patients who showed kind of major fluctuations in symptoms the positive way. So folks that improved and dropped below our threshold, that means they had limited room for improvement if they were already starting at a very low baseline symptom severity level. We made that choice of not rescreening them to be consistent with PCBH practice. We don't say, oh, you got your referral last week, but you're feeling a little bit better, or refuse to see you. If they're being bothered by symptoms, even if they're mild, we would see them, right? So that's what we were doing, but that made it a little complicated research-wise. So we wondered, is there an impact of our stratification factors? So we randomized people, keeping in mind their baseline anxiety and depression severity level. When we looked at just plots of the data visually, it seemed like the intervention was possibly better for those who had more severe symptoms at baseline. So we did post hoc secondary analyses looking at the impact of the treatment condition at different levels of baseline symptom severity. So I'm going to show you graphs for that now. So there's a lot going on in this figure. This is showing you change in the primary outcome of OASIS, symptom severity and anxiety-related impairment, across different levels of baseline anxiety severity. So we have mild, moderate, and severe going left to right. The blue bar is PCBH usual care. The red bar is the intervention condition. In people who had mild symptoms, they were about the same in terms of their change over time. No significant difference there. Same with moderates. When we get to folks who started out severe, it looks like the red bar is higher. Red bar being higher is better. That means there was more change, more improvement in the outcome. This wasn't quite significant, though. This was a marginal finding, but the pattern was generally that folks who were more severe, the intervention was slightly better. But again, with baseline anxiety severity, technically no difference between conditions. We also looked at this with depression severity. So again, the y-axis is the change in OASIS. We want a bigger change. We want a bigger, higher bar. Blue is usual care, red is intervention. With the baseline depression, we see no difference for those who were mild, slight difference, but it wasn't significant. For the moderate and severe baseline depression, the intervention condition performed significantly better. As you can see, the bar is bigger, meaning there was more improvement. So this was interesting and suggested that the baseline depression severity level moderated the impact of treatment condition. So the relationship changed depending on this other factor, which was baseline symptom severity, with the intervention being better for those who were more severe with depression. So what can we make of that? So again, if it was mild symptoms, the conditions were similar, or PCBH was slightly better, but it wasn't significantly different. But if it was mild or moderate to severe, then the intervention was slightly better. Now, this is not what the study was powered for, so give me caveats, it needs to be replicated. But this pattern is consistent with prior research. So other studies of transdiagnostic CBT for anxiety have found a similar pattern. People who had more severe depression did better when they got a CBT treatment compared to whatever, general type of counseling or comparison condition. And what we think is that folks who are milder, perhaps it doesn't matter exactly what kind of treatment you give them. As long as you give them some treatment, they're going to improve. For folks that are more severe, a little more complex, they got more going on, maybe the CBT structure, the focus on skills training, is more important, and those people do better when you give them the CBT treatment. That's kind of our working theory on what's happening here, and I'm happy to hear from others if you have other ideas. But we know that common factors are important, non-specific factors, but again, this is kind of across different studies, a consistent pattern that seems to be emerging with more severe folks, people with anxiety who have comorbid depression, they do better with CBT. Okay, I want to make sure we have some time for questions, so I'll finish my last few slides here. So this study was conducted in the VA healthcare system, so it may not generalize to other systems or other populations. I mentioned the limitation of not rescreening folks, so a 20% dropped below our target anxiety level, which might have affected our power. This was a real-world study, so there was variability in terms of what usual care involved, what modules were completed because of the modular nature of the intervention, the quality of the mass delivery. We did assess treatment fidelity for the intervention condition, but I don't have time to get into that today, but that's something we'll be looking at. But a lot of strengths of this study in terms of having a hybrid trial that attends to implementation, frontline clinicians as the interventionists. So a lot of trials use study therapists, and it's a little bit more of an artificial situation. These are frontline clinicians dealing with all the busyness of everyday practice. We included people based on anxiety symptoms, not necessarily disorders, to match what we do in PCBH. We assessed usual care, which a lot of studies don't do. And we had the active comparison condition, which a lot of studies do not do. So a lot of strengths as well. Some things we're interested in for the future are looking at the impact of the different modules, the impact of treatment fidelity. So how well the intervention was delivered. Did they do what they were supposed to do? And did they do it in a skilled manner? And continuing to look at this idea of more severe patients, especially comorbid depression, and whether the CBT intervention approach is more effective for them. And thinking about implications, in terms of our clinical work. So we saw that this modular CBT intervention performed similarly to high quality PCBH care. So in the VA system, our center, the Center for Integrated Healthcare, has done a lot of work over the past 10 years, training up the workforce and getting them to engage in effective practice. And it seems like, that people are doing well. They're delivering good quality care and patients are getting better. So that's good to know. But we think that MAST offers a good structure, especially for new clinicians who are learning how to practice in PCBH. It gives them a kind of a roadmap for sessions that is focused on skills training and keeps it focused and less likely to meander into just kind of talking about whatever the stressor of the week is type of thing. It gives people a way to emphasize active skills training. And again, it seems like there might be subgroups of patients, like people with comorbid depression, who do better with this more structured approach from the modular intervention. Thinking of potential research implications, there's increasingly attention to precision medicine and trying to tailor treatment. So we're interested in, is there an optimal combination of modules or for certain subgroups of people? Do certain modules work better? That sort of thing. And that's stuff we hope to explore in the future. Okay, I'm going to wrap it up there, and we'll have some time for discussion. I do want to show my email address and our website as well. Okay, there we go. Just looking at the chat here.
I feel tired, but you went through a lot, so that was good.
Went through a lot there, so I hope you're still with me.
I know, there's a lot of good stuff there, so I hope people will ask some good questions.
And hopefully we have, we're open to more clinically oriented questions or researchy questions or anything you didn't understand, what have you. Hi, Kristen.
Hi, Robyn. Nice to see you.
Yeah.
Former grad school colleagues, for those of you on the call that don't know. You may have said this and I might have missed it, but were the clinicians giving interventions across both arms of the
No,
trial?
they were randomized and they only saw patients in that condition. We didn't want contamination to happen and bleeding across, so we kept it separate.
Yeah, that makes sense. It's so interesting, like as clinicians and thinking about like the common factors that influence treatment outcomes. It does beg the question, right, that if you had like the same clinician delivering the different interventions, like how much does that play a role, right? Because I feel like there's lots of good clinicians, but like you get a bad clinician and this all just sort of goes to heck.
Yeah. Yeah. So I mean, common factors are real and they're powerful, right? So I think we're seeing that in terms of both conditions performing well. And then within the intervention condition, it's not only like their clinical skill level, their fidelity to the intervention, which again, we are looking at. Most people were able to deliver the intervention with acceptable fidelity, but not all. Some people did struggle with it. And one would think that would have some relationship to outcomes. We're still working on getting through those data to look at that, but a lot of different factors that could be playing into outcomes. And so, while it's fun to do a real world trial, it's also very messy and complicated and noisy.
Yeah, for sure. I wonder, like, I know it's not just alliance, but I wonder if some type of alliance measure might moderate some of the effect you see. It would be interesting.
Something to consider.
This is Mina from ETSU in Johnson City, Tennessee. I'm curious what was the amount of time it took to deliver each module, and where did you get the content for your modules?
So the module sessions were designed to be 30 minutes. Occasionally people went over some, occasionally they went lower, but on average is about 30 minutes. And we worked hard in our pilot work to really narrow it down to just the most essential stuff so that they could really do it in only 30 minutes. The content was, a very long process of looking at like 20 different manuals of different types and then, research and making it into this fashion. It was a very long process of adapting things that existed and then creating new stuff to fill in the gaps of what we thought was important. So, but I had the fortune of having a career development award, which gave me support to take stock of what was out there and then kind of spend time on the treatment development. But it was a very extensive process of generating content. The manual is quite long because it has 9 different modules and they're all different. So all the content, although the structure was the same of the sessions, the content was different. So a lot going on there.
Is the treatment manual available for us to purchase or to see, or could you point us in the direction of
Yeah,
something
you
like
can
that?
email me and I
Okay.
can share that.
Thank you so much, Robyn.
Yeah. Other questions?
You may have said this again, but how were the usual care components? You had that nice little table there. How was that gleaned? Was that from notes? Were these recorded sessions?
Yeah, so we had audio recordings of the session, and I had like master's level students, either master's in psychology or like master's in mental health counseling, people that had clinical training were the raters, and they would listen to the sessions. They had a checklist of all these different things. Did this happen or not? And so I'm going to be doing a paper just on those results because it's very interesting. Like, what are people doing when they have a patient with anxiety? Because it was all over the board. They're doing lots of interesting stuff. Some dabbling with CBT stuff, some other stuff, heavy on the supportive counseling. But whatever they're doing is working. So But it was a lot of work to get the clinicians to record all those sessions, to get those tapes, and then to rate even 25% of them. Very time consuming, but worth it, because a lot of studies don't say what they're comparing to if they do usual care. So we don't really know what that means. So that's why it was exciting to be able to get these data, even if there's a lot of them to wade through.
Absolutely. That sounds like, I mean, it sounds like you're going to follow up on that, but that sounds like a study in itself. Like, what is usual care, you know? And that seems to vary across places and settings and studies. So that was really interesting. Thanks for sharing that.
Yeah. Anything surprising to anyone, or fit with what you would have expected? Interested in any thoughts?
From a training perspective, I'm always interested in what students are doing. And you mentioned like some students were doing ratings and things like that. Can you say more about like kind of the student involvement or the training involvement in your research? I'm just curious.
Sure. Yeah, I mean, in our lab, we employ a lot of folks who want to go to grad school or are in graduate school. And the ones who have that clinical training allows them to maybe do more advanced things that, they can make sense of what's happening during a session, for example, to be able to rate it. And then in the study itself, we had a good number of interns and fellows, psychology interns and fellows, who were rotating through the PCBH clinic and were open to doing the trial. So, and then in terms of implications, we think, given, both conditions were good, but the CBT intervention kind of might be a good way to go with new trainees, because it gets them in good habits from the beginning, keeping them really laser focused on having a structure to their session, doing measurement-based care, focusing on skills training, that sort of thing. Because if you get kind of set in your ways of, especially if you come from specialty care, you're used to a looser flow of sessions, for example, it can be hard in primary care to really focus in and use the time wisely. So our thought is that it might be nice for newer folks to adopt this type of approach, just to help them stay focused in what they're doing in sessions. Anyone else with a question? All right. Well, it was a pleasure to speak with you today. And again, reach out to me if you have other questions or are interested in anything. Yeah.
Thanks, Robyn. Thanks so much for giving us your time yet again in a different format, so that people who couldn't go to the annual conference could get this amazing material. Hope everybody has a great rest of your day, and happy Tuesday, and enjoy it. And we'll see everyone again soon. Thanks again.
Mm-hmm.